Okay, the floor is ours. Thank you very much, Madam Chair. It's my pleasure to welcome everyone today. I have to really say a great welcome and debt of thanks and gratitude to the panelists who've agreed to come back again, particularly since some of them are on the West Coast with me. So I appreciate your getting up early to do this. As Jackie said, we're revisiting this issue of capacity gaps and quality in the collection of race and ethnicity data. And one of the reasons for that is that in our charge of looking at data and responding to the Secretary, we wanted to hear again from our experts to see, have things changed? Are we in the same place? Have we come up with any fixes that may be things to consider for the long haul? So one of the things that we know very clearly, and we've all learned the lesson, is that COVID-19 really exposed a lot of the data gaps in our system. And those systems that we are concerned about are not just the federal system, but state and local systems as well. And you will hear from our panelists today that a range of places in which they have had experiences about those gaps. What they were asked to do is to update us as to what is the issue that they first presented on, whether or not that issue has in any way changed, gotten worse, gotten better, and in particular, if there are fixes. They've been asked to share those recommendations for changes with us today. So I'm going to get us started. Can I have the next slide, Rebecca? So what I want to do is make sure that I introduce my co-moderator, and that's Denise Love, and introduce the panelists. Next slide. Uh-oh. No, the other way. Okay, thank you. What's going to happen today is that each of our panelists will be speaking. At the end, I'll have some closing comments, and then we will have a discussion. Denise is going to help try and keep all of us, including me, to time so that we can have a discussion. In the discussion, the way in which we'll proceed is that some of the members that are working on this small ad hoc group will be asking questions of each of the presenters, and then we will open it up to the rest of the committee for questions as well. Our presenters have wonderful bios in our packages, so we will start in the order that we have. We will start with Elizabeth Pathak, followed by Seth Spielman and David Van Riper, Betty Bekemeier, Glen Mays, Ninez Ponce, and then myself. So without further ado, is Beth with us?
And Vickie, what I'll do is give them like a 1-minute warning.
That sounds good.
Okay.
If Beth isn't with us yet.
She is.
Beth, I think you're muted.
Is that what it is?
Thank you, whoever. Yes, I was muted. Sorry. Good morning, everybody.
Good morning, my friend. I'm glad to have you here. So
I had to mute myself because, of course, I started having a terrible coughing fit, 2 minutes before I have to give my talk. So,
well,
but I have my water bottle.
COVID.
Hopefully, we'll make it 15 minutes with no coughing.
Okay,
so,
thank you.
Greg, I can just share the screen, right?
Yep, you should be able to right now.
Okay. All righty. So last year when I talked to you folks, the title, Vickie asked us to keep the exact same title. So the title is Measuring Racial and Ethnic Disparities in COVID-19 in Children and Teens, the Problem of Missing Data. So I'm going to give you a brief update. And unlike last year, I don't have a ton of slides. I decided let's really pare it down, just have a few slides so that we have more time and hopefully time for questions and answers. So I'm going to cut to the chase and just tell you right now that we have seen only minimal improvement in this issue. That's the bottom line. We really haven't made much progress since last spring. So let me get into, let's see, how do I think if I do this? Okay, I just want to acknowledge my collaborators on the COVID project. Dr. Janelle Menard, Rebecca Garcia, who's a nurse practitioner, who's our clinical expert, Dr. Jason Salami of the University of South Florida. Some of you may be familiar with Dr. Salami. He's become one of the COVID news celebrities, especially in Florida, and runs a dashboard, which is really outstanding. And we've added a couple new people in the past few months. We now have a postdoc, Dr. Megan Berry, who's working with us, and a doctoral student, Justin Swanson, also at USF. And we remain a volunteer effort. So just a brief reminder on COVID-19 data and kids. And this is just a repeat from last spring. To understand incidence of disease, we need testing and case data. To understand disease severity, we need hospitalization and intensive care admissions data. And to understand disease fatality, we need death certificate data. And to understand racial and ethnic disparities, we need all of these types of data because we need to understand the racial and ethnic dimensions of all the aspects of the disease. So it's quite a challenge. And as you're already aware, we really lack racial and ethnic data for most of these data points. I just want to make a note that one of the things that has changed since last spring is that we've updated our census population denominators. In the COVID project, we are using the latest census 2020 population denominators when we calculate our rates. This is important. It's important that everybody update to those 2020 denominators because there are some states in which population declined. There are some states in which population went up. So it's not like, oh, well, you know, the population grew, every state is a little bit more people. It doesn't work like that. Some states actually went down from those vintage 2019 to 2020 estimates. So that impacts rates and it impacts our comparisons across states. There are many state dashboards out there that are still using old population denominators. They're using 2018, 2019, they haven't updated. And there are national analyses and things that get published where they're not using 2020 population denominators. So that's an easy fix, I think, that everybody can do because the data are available. It's just a question of updating what we're doing. Okay, so I'm going to present just a little bit of information about case data. So the main thing that we have done, the COVID project, what we do in COVID is we visit every state dashboard every week, and we extract all available COVID-19 case data for kids. Now we use the word kids because the age range varies by states. We don't have consistent reporting. Some states report 0 to 17, some 0 to 19. Those are the two main categories that we get. There's a couple that report 0 to 18. There's 3 states that report 0 to 20. And for Utah, we have a strange age range because of the way that they report data. So in the CDC restricted case file, which is released to researchers and is supposed to include all of the cases that CDC gets from the states, we compare our COVID counts to the CDC counts. Now, you might think if states are reporting the data to CDC, it should match, right? What's on their dashboard should match what they're reporting to CDC, but that's absolutely not the case. The data don't match, okay? And there's different reasons for that. And the reasons vary by state. So we've updated this with data basically through right before Christmas from COVID, and then the CDC, the latest CDC restricted file was released on January 10th of this year, 2022. The cases really go up through December 23rd. They have a few cases through the 26th, but the counts are incomplete. So we cut it off at the 23rd, and our 24th data really is counts through the 23rd. So these dates really match up pretty well. And you can see that the COVID total is 9.3 million on that date. Now we're well over 10 million now with the Omicron surge. And the CDC total is 8.4 million. Now, a key thing to keep in mind is that the comparison varies state by state, and I'm not going to get into those details with you, but it is something that we're looking at and analyzing. So for some states, we have very good comparison between COVID and the CDC restricted file. However, there are some states where they're basically just not reporting data to CDC at all by age. Okay, so, and this gets confusing. So take a state like Texas, they report their total case counts to the CDC, but when it's broken down by age, they don't report it. So we don't get any kid cases for Texas in that CDC file. For COVID, we calculate those estimates using local health department data from Texas to get a good estimate of the number of kids who've had COVID. And right now it's over 1 million. Just in Texas alone. Now, sometimes the CDC total is higher than the COVID total. That happens when the state dashboards only report 0 to 17, but the CDC restricted file has 0 to 19. So sometimes the CDC restricted file totals are higher than the COVID totals. So it varies state by state. But the key thing that we're interested in with race and ethnicity is how is the reporting going? And I'm going to try to zoom in on this a little bit. So this is basically a map of the most recent CDC data, and it shows the percent of cases for 0 to 19-year-olds who had missing race and ethnicity. Now, you can see that these numbers are still pretty high across all states, but I will say that they are improved somewhat from last spring. Right now, the national average is 29.9% of cases. In the spring, it was around 40%. So we have made some incremental progress, and that's good news. But if you look at state by state, you can see that in 2 of our biggest states, in New York and Texas, the numbers are pretty high. New York is very bad, actually. And I have a feeling that that reflects a New York City versus New York State split. I would guess that we're getting the race and ethnicity data from the city, and we're not getting it from the state. New York State has one of the poorest, in my opinion, dashboards. They don't report any demographics for the state on their dashboard. It's just kind of incredible, but it's the truth. Now, Florida looks really good. Only 12.4% of kid cases are missing race and ethnicity. But here's the problem with Florida. The entire reporting of child cases to CDC is missing about 35% of all cases. So in other words, from the dashboard, COVID, and from the weekly reports that the Florida Department of Health puts out, we know what the total number of cases is. In the CDC restricted file, it's only about 2/3 of the cases. So those 2/3 have good race and ethnicity reporting, but we're missing a whole bunch of cases. So you can see there's still quite a ways to go to have uniform, high consistency, high reporting of both the underlying cases, the denominators, and the race and ethnicity data for those cases for kids. So bottom line, we've made a little progress. We still have a long way to go on this, a long way. Now, I want to mention the intensive care data, because this is something that I was very enthusiastic about in the spring. And I'm just going to share my slide from the spring. Okay. So this, let me zoom back out here a little bit. So this is from a registry, a voluntary hospital registry of pediatric intensive care units. And they had race and ethnicity data along with very rich clinical data on these kids who were admitted to PICU. And at the time of this, so this is through March 28th, they had data on over 1,800 patients. And remember, this is a voluntary registry, so this does not capture all of the PICU patients up to that point in time, just a fraction of them. And I'm personally aware of some of the major children's hospitals which were not participating in this registry, like Children's National in Washington, D.C., and Boston Children's were not in the registry, okay? So this is what we had even without those big hospitals. And you can see that the majority of patients were Black and Hispanic, non-white. Only 27% of these PICU patients were white. The majority were racial and ethnic minorities. So I wanted to give you an update on this, and it's not good news. This voluntary registry ceased operations on April 1st, basically a few days after I put my presentation together. They decided that they couldn't afford the resources. They were putting a lot of their nurses focused on the COVID data, and they just decided they weren't going to do it anymore. Now it's still up on the web, so you can go, and it's data through April 1st. Has not been updated since then. But I really encourage people to look at this registry, the VPS registry, because, and I think the link is on this earlier slide, okay? The link is right here. It's really a model, it's really well done, and it's really a model for what clinical registry data could and should look like for COVID-19, for kids. And, you know, it's one of my dreams that we would have registry, that level of clinical information available for all of our pediatric hospital patients, which is, you know, tens of thousands at this point. Okay, so let me now talk very briefly about the death data.
I'm going to give a 1 minute warning just to keep
Okay.
on time here.
Okay. So the big, very good news that has happened with race and ethnicity and death data is that NCHS has put provisional COVID-19 death data on CDC Wonder. This is a huge accomplishment. I know it was a huge amount of work for them to do that, and it is a true gift to the research community and to the broader public health community, because now researchers can go in and customize their tabulations for what they want to look at with COVID-19. Previously, we were limited to the tabulations that NCHS chose to put out, and they were doing a great job. Every week they were putting out, you know, I mean, several, maybe a dozen or 2 dozen files with special, you know, particular tabulations. But CDC Wonder just gives us a lot more flexibility. What this slide shows is the discrepancy in death counts across data sources. Okay, so when we go into state dashboards, we count 782 cumulative deaths. But remember, many states are only reporting 0 to 17. In the CDC restricted file, there are 1,500 child and teen cases identified as deaths. In CDC Wonder, for 0 to 19, there are 992. Now, why is this number higher than this number? It has to do with deaths among cases versus having COVID-19 mentioned as a cause of death on the death certificate. Okay, and we could have a whole long conversation about what's the meaning behind all of that, and under ascertainment and misclassification of cause of death. We know that this is an issue, and it's something that needs to be explored further. So, but just to finish up, I just want to show you, these are the death rates, and this is the CDC Wonder data. So these are death rates by race and ethnicity. So the number on top is the death rate. The number in the box is the number of deaths, okay? Now these are hatched because NCHS says don't calculate a death rate if you don't have 20 deaths, all right? For NHOPE kids, there's been 8 deaths nationally over the 2 years of the pandemic, okay? It's a small population, so we would expect a small number of deaths because the population itself is so small. American Indian, Alaska Native, and these are non-Hispanic There's an additional 5 deaths, which are Hispanic, and they're included here in the Hispanic group. And then just focusing on the big 3 that account for 90% of the population at risk, non-Hispanic whites, Blacks, and Hispanics. These are the death rates and the rate ratios. This is through the end of December. Now, these disparity ratios have actually come down a bit because the Delta wave and the later waves have hit more of the non-Hispanic white population than had happened earlier. So earlier, the rate ratios were higher than this for Blacks and Hispanics, but still a big discrepancy for the non-white kids versus the white kids. And let me just close by encouraging you to visit the CoKid project. This is our latest dashboard. We'll be updating this in another day or 2. And you can see here, this is the average daily incidence. Here's the Delta peak, which seemed so high just a few months ago. And it's been totally eclipsed by where we are now with Omicron. And this is cumulative incidence. We have hospitalization data, death data, vaccination data, and a lot of interesting information there. I'll skip all the way here to the end. And there is my email address and the CoKid project website. Thank you very much.
Thank you, Beth. That's fascinating, fascinating. We'll tee up to the next panelist, and then Vickie, we'll do questions and discussion at end, right? Not after, okay.
Is that us?
Yep.
Okay, awesome. Let me do the thing. Great. Are we thumbs up if you see us? Great.
Yep, you're good to go.
Okay. So David and I sort of did a quick review of our slides in terms of an update, and parts of our presentation have changed to reflect sort of the evolution, in particular around the 2020 decennial census, and parts are the same because other aspects haven't changed. And so we'll move pretty quickly, but I think tee up questions, and happy to sort of talk later. So we're talking, David and I are talking about sort of the 2 primary national sources of sort of denominator data, right? So race, ethnicity data, things that give you population counts. And the 2 big sources of information for that data are the American Community Survey and the decennial census. The American Community Survey is a sample of housing units. They contact about 3.5 million, 3.5 million housing units each year. They get about a 60% response rate. That's pre-pandemic. During the pandemic, it's been very difficult to operate the ACS, and the planned releases have been delayed. But the important thing about the ACS is that it's a sample of the population, as opposed to the decennial census, which in theory sort of counts everyone. And the new thing about the decennial census, the 2020 decennial census, is that some new disclosure control methods have been adopted that sort of changed the nature of the data. And David's going to talk about sort of where that's heading. So in terms of the American Community Survey, one of the things, what our goal today is, in the first half, the goal is really to talk about the quality of the demographic data, in particular the population counts in the American Community Survey. And the way that we did this the first time around, and we'll just quickly revisit this now, is through plots that look like this, and I'll just briefly explain how these work. On the y-axis, well, let's start on the x. On the x-axis, we have sort of the number of people in a given race ethnicity group in a census tract. So as you go from left to right, the population in a given group gets bigger. In this case, we're looking at the total Hispanic population. And on the y-axis, we have the margin of error in that estimate. So as you go higher and higher, on the y-axis, the margin of error gets larger and larger. These colored lines, the red line represents places where the margin of error is equal to the estimate. So any dot that is above the red line means that you have a case where you have a census tract where in this case, the Hispanic population is 1,000 people, but it might be plus or minus 1,500 people, meaning that somewhere between 0 and 2,500 Hispanic people live in that census tract. The yellow line is 50%, so meaning that the margin of error is 50% or more of the estimate, and the green line is 10% or more of the estimate. So in this case, when we look at the Hispanic population estimates by census tract in the United States, we see that 15% of all census tracts are above the red line, meaning that the margin of error is greater than the estimate. So we know it's somewhere between 0 and something. 53% of all census tracts for the Hispanic population have a margin of error that is 50% or more of the estimate. So it might be 100 people plus or minus 150, and 99% of all census tracts have a margin of error that is greater than 10% of the estimate. So there's a fair amount of uncertainty in estimates of the Hispanic population. If we just look at total population, the story is much better, right? Very few census tracts, sort of go above the red line for the total population. Very few go above the yellow line for the total population, and about 35% are above that green line, meaning 10% or more. And if we look at all of the different race ethnicity groups that are, this is not all, if we look at sort of the big 5 categories, excluding Hispanic because it was on the prior slide, if we look at the African-American population, 26% of census tracts have a margin of error that is greater than the estimate. About 60%, it's 50% or more of the estimate. If you look at Native Hawaiians, about 90% have a margin of error that is 100% or more of the estimate, which makes the data really hard to use. Asian population, it's about 40% are above that that red line, and American Indian, Alaska Native, about 80% are above that red line. And so what we see is really substantial levels of uncertainty in the race ethnicity data from the American Community Survey. That's at the census tract level. Now, if you look at larger units of geography, all of a sudden the story gets much better. And so here we're looking at the Hispanic population by county, and we can see that very few census tracts sort of are above the red line. About 10% are above the yellow line, and most are even have a margin of error that is less than 10% of the estimate. So the scale at which you look at things really matters for the quality of the estimates. County works well for certain things. If you want to look at intra-urban variation, county isn't great. Last point is that not only the geographic scale, but the demographic scale at which you look at things matters. So looking at the total population gives you a low margin of error. Looking at the population that's aged 65 and up gives you a slightly larger one. If you look at the Hispanic population, it's larger. And if you looked at the sort of cross tabulation of those 3 things, female Hispanic women, Hispanic women over age 65, you can see the margins of error kind of blow up. So some quick solutions. We have a couple of different solutions that we've sort of put out there in the public domain. One is ways to sort of re-engineer census geographies. We can think of them as sort of Goldilocks geographies, that is, ways to automatically or predefine units that are bigger than a census tract, but smaller than a county, that give you nicer estimates. And then we also have an approach where we sort of take a bunch of different variables and put them together into a data product. So rather than looking at one variable at a time, you look at a composite of a census tract, and we think that gives you a cleaner picture and allows you to differentiate census tracts in a more meaningful way. There's links to all of this in the slides. And with that, I will hand it to David.
Great, thanks, Seth. So I'm going to update, I would like to update people on the kind of the status of the 2020 decennial data and the products that are coming out from it, and give you an update both about the status of the products, some proposed changes that the Bureau is making to the products, and some forthcoming demonstration data that may be of interest to the panel and to other people who are kind of participating in the call. So next slide. So in terms of the status of the 2020 decennial census data, there are 3 main products that research scientists, demographers, population scientists tend to use. The PL 94-171 redistricting data, which is used for legislative and congressional redistricting within states, it has been released since our last meeting. Those data were released in August of 2021. That was 5 months after it was originally planned for release in the March-April 2021 time period. Those data have race and ethnicity counts for persons below and above age 18. We don't get that fine-grained sex or age distributions that many demographers and public health scientists want, but this is the first product that's been released. The demographic and housing characteristics file, which is formerly known as Summary File 1, is tentatively planned for release in mid to late 2022. We don't have a finer grained estimate than that. This is a delay of 1 year compared to prior decennial censuses. So in the 2010 round, Summary File 1 was released in July and August of 2011. In 2020, we're looking at a delay of at least 1 year, if not longer. The detailed demographic and housing characteristics file, which is formerly known as SF2, we actually have no current timeline for release. The Bureau has not yet specified when those data are planned to come out. They're typically released 6 months after Summary File 1. So this would put the release of these data into the mid 2023 time period. So that'd be 1 to 2 years after it typically comes out. So why do we have these delays? There's really two main reasons. One, the COVID-19 pandemic wreaked havoc on the Census Bureau's schedule for collecting census responses and doing the non-response follow-up. They delayed the end of data collection until October and November of 2020. This pushed back their data processing and quality assurance and quality assessment perspectives. So that pushed it out. The second, though, is changes to their disclosure avoidance system. The Bureau has to create their disclosure avoidance parameters for the DHC and the DDHC and then run them through the system. This requires substantial review and testing. And prior disclosure avoidance techniques were run once on the individual census responses, and then all products flowed out from that single disclosure avoidance technique. So now they have to rejigger their algorithms and reset their parameters for each product. Next slide. And that leads into my next bullet point. There will be some new demonstration data coming out in the next couple of months from the Census Bureau. This demonstration data product will contain the data tables that are proposed for the DHC release. So we're going to get sex by age, by race, ethnicity. We're going to get household type structure, household relationship, and housing tenure. And the Bureau is putting these out in advance of setting the final disclosure avoidance parameters. We are going to be able to compare this demonstration data, which is based on 2010 responses, with the originally published 2010 data to see how different the sex by age, by race, ethnicity counts are, and whether or not the discrepancies make them fit for use for a variety of use cases. And I would think that the vital statistics and public health researchers on this call will find that of particular interest. Next slide. The other thing that's happened since our last meeting is that the Census Bureau has proposed some pretty substantial changes to its data products, and I want to highlight 3 of those here. First, the Bureau has announced that they plan to release some new census block data tables in the DHC. In particular, they're going to release sex by 5-year age bins, by race ethnicity, for many more race ethnicity combinations. So we're going to get more sex by 5-year age bins by race ethnicity than we had in prior data products. But while they're releasing some new data tables, they're taking a few things away. And in particular, they're reducing the geographic detail of a subset of tables, and they're proposing the elimination of some data tables. Next slide. With respect to the reduction in geographic detail, the Bureau proposes to move 69 of its data tables that were previously available at the block or tract level up to the county level. So county will be the smallest geographic unit for which we will get these 69 data tables. And as Seth helpfully mentioned in his talk, getting those data at the county level means we're not going to be able to know anything about intra-urban variation. So we're going to get one count for Los Angeles County which includes 10 million people, and we're going to get no detail within LA County. But we're also going to get a count for Loving, Texas, which has 64 people in it. So that variation, that size variation at the county level is going to make it hard for us to really dig in deep into counties for these data sets, for these tables. Next slide, please. In addition, the current proposal eliminates 169 data tables from Summary File 1 DHC, and 67 out of 71 tables are proposed for elimination in the detailed DHC. Next slide. And I want to bring your attention to 3 of those data tables in particular. So in prior decennials, the Census Bureau released the counts that were single year of age by sex, by race, ethnicity at the census tract level. So that was really helpful because you could get down to those, children 0 to 3 by race, ethnicity, and look at potential lead poisoning rates or other kind of things that were particularly targeted towards people of particular age groupings. Those will not be available anymore. The trade-off is we're getting more sex by 5-year age bins by race, ethnicity combos. That's the trade-off we're getting here. But for people studying particular age groupings by race, ethnicity, that will go away. They're also proposing the elimination of Hispanic origin by specific origins. We no longer get the counts of people identifying as Mexican or from Mexico or from Ecuador, where they were born. They're also proposing the elimination of its allocation count table. That tells you something about how many people did not respond with an age or a sex or a race response, and that had their data imputed in the final counts. So it gives you a sense of the quality of the counts for particular geographic units. Those are also proposed for elimination.
1 minute warning.
Next slide. So great timing. This comes to our conclusion. And so, from the ACS and decennial, I think as Seth talked about and what we know about the small area data from the decennial, we can get good city level rates and population estimates. Now within city or within county is a little trickier to understand. Geographic and demographic resolution matter, and you're kind of dealing with a trade-off here, right? The finer grained one of those groups the counts get smaller, the uncertainty around those counts increases, making it harder to know exactly what's going on for those geographic or demographic groups. It's possible to process the publicly released data to improve estimates, in particular for ACS data. Seth and his research group have done a great job looking at how to aggregate geographic units upwards or demographic groups upwards to reduce those levels of uncertainty. Based on what we know about the 2020 decennial, it's going to be much harder. As of today, the Bureau is not publishing error bounds on its 2020 counts. So it's going to make it a lot harder for us to be able to do aggregations to reduce that uncertainty. Next slide. I think that's it. Thanks, everyone.
Very good. Thank you so much. The next panel. You're on mute, Vickie.
I was going to say, I think we have Betty next.
Okay. Welcome, Betty. Thank you. And you're on mute.
There we go. Thanks, everybody. It's hard to get yourself off mute once you got your slides up. Okay.
We don't see your slides, just so you know.
Oh, you don't?
No.
Are you able to share your screen?
I thought I was.
Could you try sharing again, potentially? If you hit the share screen button at the bottom in green, then you should be able to get a pop-up with all the different windows you have open. Then you have to
There
make
we
sure
go.
to. I see something loading now. There we go.
Okay.
Great.
All right. Thanks, everybody. And you see the full screen, I think.
Mhm.
Yes.
Hang on a second. I'm trying to get back. There we go. Hang on. Okay. So my talk is very different. I'm talking about what we're doing at the practice level, at the public health practice level in terms of data, if you recall from when I was with you last. And I'm going to be talking about work we've been doing in terms of focusing on building capacity for and with governmental public health systems, and with a particular focus on assuring that we attend to rural areas. So one example I'm going to be talking about again is this Share Northwest project, which largely serves capacity building needs and data needs of public health systems in our Region 10, Washington, Oregon, Idaho, and Alaska. And I'll be referring to this Share Northwest project today about making health status and social determinants of health data more accessible to rural public health systems in our region. And then another is from our FAST team, PHAST, that stands for Public Health Activities and Services Tracking. And for which the FAST team, we've been working with public health systems to standardize their administrative data, governmental public health administrative data, for its use in more equitable and data-driven decision-making. So I kind of go back and forth between administrative data and health status data, and I'll be talking about this again. So I talked about this some last time, but in terms of public health status data, in our Share Northwest project, working on health status data, we focused only on rural local health departments, and many of these data gaps and access and use we identified here are true for non-rural agencies too, but they're particularly acute in rural areas. They continue today. When I talked with you in April, we'd recently interviewed rural public health leaders about data gaps, in particular during COVID. And they talked a lot about being overwhelmed by the data volume during COVID, about being nervous about data trustworthiness. As you can tell by the previous presenters, there was good reason for that. Lack of capacity for assessing and ensuring data quality for communicating with data, and lack of data for underserved groups. And then in terms of public health administrative data, the last time I talked to you, I was distinguishing between public health administrative data versus community data for public health status. And again, both are critical to addressing health equity and our particular problems in rural areas. I mentioned then that because of administrative data inconsistencies, it's generally been impossible to compare agencies, to look at best practices or measure public health impact of their services or resources, and particularly, in their application around COVID, et cetera, it's been impossible. So because no standards have existed for the 2,800 local health departments across the US for measuring prevention activities, their expenditures, et cetera. And this lack of comparable data has limited the extent to which policymakers, researchers, public health practice people can generate the evidence they need and make data-driven decisions around allocating resources, including in response to COVID pandemic. And this really has been exacerbated dramatically in rural areas. So since I talked to you last, there's been growing attention paid to meeting the needs to estimate the type of an amount of workforce needed to address public health crises. There's a lot of interest. Folks have been, crying out for, how many people do we need to do this, to do contact tracing, to do epi follow-up and surveillance and et cetera, but there's been no way to answer that. So we're really working on that now, since a lot more increasingly since I talked to you last. Last time I talked, we also, I was talking about, we were helping the bridge, our team has been helping bridge this gap for public health systems to have data, to have useful access to the data. It's one thing to have data, but when you're a local public health practice partner, person needing to make decisions around data, you have to have good access to it, meaningful access to it. and then have the capacity to understand and leverage the data for community level decision making. So we've been using this model for ourselves, and the circle portion here highlights how important it is to put tools in place for data to be actually available and used by those in practice. Possible channels to make data more accessible and usable are things we've been working on, such as a centralized web-based data reporting tool, user-centered data visualizations, a dashboard that's really useful to people in practice, particularly in rural areas, training and education on interpreting data, how to use data and data visualization. All of these channels need to be attended to for effectively filling these gaps between data public health systems in practice and how to use it for generating evidence, et cetera. So with some of our current Shared Northwest funding, this funding comes from the Office of Minority Health. We've identified these more immediate solutions we can bring to rural partners and for each of these data gaps. I won't go through them all, but you'll note that a lot of the low-hanging fruit here is in the form of capacity building or providing training in data use and understanding what the data mean, et cetera. So we've done a lot of work in that area. And this other in the dashboard was finally launched. Our dashboard was finally launched in August and is entirely focused on what rural users have asked for, the data they've asked for and wanted and given us feedback on. And this includes now the development of an infographics tool that they can easily populate and use in communicating with stakeholders. So here's a screenshot now of the homepage of our Shared Northwest dashboard. These topic areas are each have a dashboard that was commonly asked for by our rural users and in support of addressing disparities in their communities. They use existing county level data that we pulled together and linked. These were data that they were previously going all over the place and looking here and looking here and looking here. Now they're all linked together. And we've linked them together with social determinants of health data so that, and we provide steps for the users in terms of how to make connections between community health status and these underlying determinants. We did the best we could with county level data that we could find, but of course, rural data by race and ethnicity were hard to come by. So the dashboard does a lot to encourage users to dig deeper and ask community level questions about who might not be represented in these data, what factors may be marginalizing specific populations that are represented here, and a lot of other questions like that. So the data don't always, often don't exist at the race and ethnicity level in rural areas, but we're really also providing tools for people to ask deeper questions and collect more data at a local level, et cetera. So while we've been working hard on development of this user-centered dashboard with linked data sets and information specifically for rural communities, results of some of our more recent interviews with rural public health leaders regarding COVID-related data issues led to our decision to add development of an institutional discrimination dashboard. So with these dashboards you see here, that we're going to be adding this institutional discrimination dashboard to add to our other health status dashboards. These data will include things like residential segregation, home ownership by race, school segregation, income inequality, jail and prison population data by ethnicity, elections and voting data. And these are data where we might expect to see greater disparities during a public health crisis and having broad range or impacts. We've also recently been hearing more from our rural public health practice partners that they'd like to keep track of where the COVID hotspots have been at a local level around their state, so they can watch for and respond to future ongoing needs that these populations might have as a result of COVID. we're thinking now about how to help address that, but it's a really interesting request. Another part, as I mentioned, we also found great gaps in capacity and understanding and communicating with data and the need for related training. So we curated existing trainings and have put them in bundles on our website too, but we also found gaps in training that needed to be developed. So we did that. So we developed 3 new online training modules. There's a series focused specifically on data for advancing rural health equity. These modules are presented through a narrative problem-based learning format where the learner steps into the role of a public health promotion specialist in a rural health department. And we used the rural health department as a model, and they helped us with this, etc. And then in terms of agency level data that local health departments need for more equitably allocating resources and tracking where their resources go. As I mentioned, local health departments have had no standard way of reporting financial information. So although public health funding has been declining for decades, it has recently been in the spotlight because of COVID and how under-resourced local health departments are for most emergencies, certainly a pandemic like this. So over the last 5 years, our FAST team, Public Health Activities and Services Tracking Team, has developed and been testing what we call the Uniform Chart of Accounts, and we've been doing that with health departments. It's a standard way of reporting public health finance information to show what exactly is being spent on programs such as communicable disease control, all hazards, preparedness and response, individual services like these. So more and more agencies are crosswalking their data to this standard system that we've built for this kind of to bridge this gap between what public health practice needs and wants and how these data can be used. So since I talked to you last, we've now public health agencies are trying to figure out what kind, and they've been doing this for a little while now, but what kind of staff and how much they need for responding to health needs in their communities and these emergencies. So in collaboration with these 4 groups that you see at the bottom of this slide, including our FAST Uniform Chart of Accounts team, there at the bottom right, we've all been working together to provide these data needed for what we're calling staffing up local health departments. In phase 1 of the staffing up project that took place about a year ago, that led to this initiative to develop a national estimate of FTE, the FTEs needed to perform what we call foundational public health services in the US that every county, every jurisdiction should have access to. So the conclusion from phase 1 was that state and local health departments needed an 80% increase in their workforce just to provide adequate infrastructure and a minimum foundation of public health services. So now in phase 2,
1 minute warning.
Okay, in phase 2, we're all about creating a locally usable tool to determine staffing needs at various levels. So we're working together on this workforce calculator for public health agencies. It'll be a resource for the type and number of staff they'll need. And we're using the main data source for this is this Uniform Chart of Accounts data, because financial data are largely reflective of public health staffing. So our team is working to gather more health departments into the Uniform Chart of Accounts and provide those data to feed the calculator. So some of our larger lessons learned are that the data have to be made accessible and designed for the users and for engaging partners. continues to be a very high need and interest in training and data use. When we launched our training series and we had a live portion of it, overnight, we had 125 people register, way more than we expected for our first pilot. We had to close down registration. Resources are needed for oversampling and data collection in rural areas and for tracking COVID hotspots into the future. For public health administration data, there's continues to be a need for standardization of data and this takes resources and time and coordination and potentially mandates and incentives. And I'll go ahead and stop there. All right.
Good work. It's fascinating. I wish we had so much more time. So Vickie, is Glenn the next one on the roster?
Yes, it's here.
Okay. So Glenn, it's all yours.
Fantastic. Well, greetings, everybody. Thank you again for the opportunity to join you, share some insights from our perspective. I'm going to continue along on some of the themes that Dr. Bekemeier raised and her work from a slightly different vantage point, looking at what we're seeing in terms of local public health and community partner access to race and ethnicity data during the COVID response. A vantage point from a national perspective through several large national research networks that we lead that involve local public health, working with medical and social service partners at the local level. And just as a reminder, three major research initiatives that give us the lens for kind of studying these issues and how they're playing out in local communities across the country. All of these are research initiatives that are funded by the Robert Wood Johnson Foundation. First is a national longitudinal survey of local public health delivery systems that we've been maintaining over time now for more than 20 years. Originally started with CDC funding and now continued in recent decades with RWJF funded. That allows us to follow about 600 local communities, local public health jurisdictions around the country, nationally representative, by following them, by doing surveys every 2 years to study public health activities implemented by those agencies and their community partners, and the constraints and challenges and opportunities they face in delivering public health services, including looking at issues around data capabilities. The second is the National Health Security Preparedness Index. This is another initiative started by CDC and now continued by RWJF. This allows us to aggregate data from about 100 different sources to produce annual county level estimates of public health preparedness and response capabilities. And the third research lens that we use for this is the Systems for Action National Research Program, another initiative of the Robert Wood Johnson Foundation, where we're able to study at local level initiatives that involve helping public health agencies work together with medical and social service providers to study and address issues of health equity in their communities. And we've now got about 36 studies funded through that program all around the country. Almost all of them involve exchange of health and social services data between those sectors: public health, medical care, and social services delivery. So the updates I'll be giving you here quickly derive from looking across these three national research initiatives. So what have we seen since the last time we talked to you about access to and use of race and ethnicity data by local public health and community partners? Very similar to the findings you heard from Dr. Bekemeier and her vantage in terms of public health practice partners. We have seen some limited improvement, particularly in large urban public health jurisdictions, in those public health agencies gaining access mostly to state public health surveillance systems that have improved completeness of race and ethnicity data. This is also, I think, consistent with some of the comments you heard from our first speaker as well. So limited improvements in addressing gaps in getting access to racial and ethnic data, primarily through state public health surveillance systems around COVID. And it's the larger urban local public health agencies that are reporting better ability to get access to race and ethnicity specific data, particularly around getting data, race and ethnicity specific data on cases, hospitalizations, deaths, and to a more limited extent, vaccination rates. Still reporting gaps in terms of incomplete data, unknown race and ethnicity data in all those data sources, but we are seeing hearing reports of improvements, again, particularly for larger urban jurisdictions. We're seeing less progress around getting race and ethnicity specific data around testing, positivity rates, occupational exposures, workforces reporting exposures and outbreaks, and then the general area of getting data on unmet social needs related to populations affected by these conditions. Along with that, a number of other problems that I talked about last spring, we're seeing really much evidence of progress in some of these other data access issues that local public health and community partners face on the bottom half of this slide. Still, our partners in research networks reporting missing and incomplete race and ethnicity data that are being collected through locally collected data collection processes, particularly through case reports and contact tracing activities that are managed through local public health agencies. Still big problems with missing and incomplete race and ethnicity data from those case reports and contact tracing. That are primarily attributable, again, as Dr. Bekemeier mentioned, to limited staffing at the local public health agency level to be able to do follow-up for missing data and to do verification, and linkage to try to address incomplete race and ethnicity information on case reports, on outbreak reports, and on contact tracing that are driven through local public health agency data generating processes. Similarly, point number 2, ongoing problems with limited access to administrative data sources that have important information about populations affected by the COVID-19 pandemic. Very limited local public health agencies reporting being able to access data from all payer healthcare claims databases that are available now in more than 30 states. Local public health not getting access to claims data, not getting access to timely state Medicaid data systems, reporting lack of access to statewide hospital discharge data systems that are available in now about 46 of our 50 states. And very low access to statewide social services administrative data systems like SNAP, WIC, unemployment insurance, and others. So this is a barrier in access of local public health being able to access state administrative data systems. For the small number of agencies that report having access, they are still reporting large problems with incomplete race and ethnicity data in those administrative data sources, and limited ability at the state level for cleaning and addressing those incomplete data through data linkage and verification processes. So this is we've seen evidence, very little evidence, really no evidence of progress in solving these administrative data access and information issues. Thirdly, we talked a little bit about emerging opportunities last time with public health access to regional health information exchanges, and even more recently, the regional social health information exchanges. We're continuing to see very little progress in opening up access to public health agencies and other community partners into those exchanges, which are primarily built around access for large healthcare providers, hospital systems, and physician practices to have access. Public health, local public health, and even state public health continuing to express challenges with gaining access to those systems and race and ethnicity specific data from those systems to use in COVID response activities. A few other data points to note, and these are data mostly coming from our National Longitudinal Survey of Public Health Systems across the country. More than 50% of local public health agencies report no or limited ability to examine issues of racial equity as part of the community health needs assessment processes that public health agencies conduct on a 3- and 5-year cycle. More than half of public health agencies around the country reporting not being able to consider issues of racial equity in their community health needs assessment processes. This is a big problem, and largely due to that limited access to race and ethnicity data. They're not able to incorporate this information meaningfully into the community health assessment processes, and then more downstream into their community health improvement plans that are developed and updated on an ongoing basis. Another notable statistic, 63% of the public health jurisdictions in our longitudinal survey report no or limited ability to allocate public health resources based on analyses of racial equity around in priority health needs through their community health assessment process. So they're not able to meaningfully incorporate issues of race and racial equity into their assessments, and therefore they're reporting a limited ability to allocate resources based on their assessments with attention to issues of racial equity. Large gaps in the ability to practice evidence-based public health because of these gaps in access to race and ethnicity data. And obviously, as Betty mentioned and others, in rural jurisdictions, this problem, these constraints are much larger, much less likely to report the ability to consider racial equity in their assessment processes and in the resource allocation processes. Interestingly, this last point, we're finding that those public health jurisdictions around the country that report limited ability to do this kind of racial equity assessments and analyses, those places over 2020 and 2021 have experienced significantly higher rates of death rates from COVID-19, not surprisingly. This is just a correlational analysis that we've done at this stage. We can't infer causality here, that it's the limited access to racial data that's driving the higher mortality rate, but there's a clear troubling pattern there. The places with experiencing the largest gaps in access to data are places that are having disproportionate burden and health consequences from COVID-19. So finally, just some thoughts for improving some of these gaps in access, and this is going to be very consistent with what you heard from Dr. Bekemeier and others. Number one, if we want to improve access at the local public health level to these data and the ability to act on race and ethnicity specific data at the local level, we've got to expand staffing. Staffing constraints are the largest and most immediate problems here, especially more local public health workers, as Betty mentioned, that 80% estimated additional need, but in particular, more public health workers at the local level with specific data science training and skills. That relates to the second point also mentioned by Bekemeier, the need for expanded training for local public health workers, particularly in data skills, data collection, data access, and data analysis. I would note that there are components in the American Rescue Plan that are earmarked for building capabilities at the local public health level. Most of those additional dollars that are allocated to local public health are non-recurring funds. And so what we're hearing from public health stakeholders is that they're reluctant to invest those new federal dollars in new hires because those are dollars that are going to disappear. Investments in training, however, could be a good use of one-time funding. It's not clear to us that the training that's happening is really earmarked for these issues of data access and data use at the local level. So that's worth some additional attention. Third, the need for improved data infrastructure to facilitate local public health access to state and regional data systems that exist. They're there. Local public health is reporting inability to be able to access them. So more investments in creating secure data portals that will allow local public health data analysts access into our surveillance systems, into administrative data sources, and the regional health information exchanges, really, really important. That could also be good use of existing, federal dollars, especially non-recurring dollars, into infrastructure that have, one-time costs, but potential benefits over a larger time horizon. And then finally, what locals are telling us is that their states need additional capacity to fulfill local data requests and requests for local analyses. That means the staffing and the training needs are not just at the local level, but they're also at the state level. For states need to have additional capacity for meeting the local data needs and data requests that are coming from their communities with a specific eye toward race and ethnicity specific data. Last point I'll mention is that I'm not going to go into details because I think one of our other panelists here, Dr. Who has served on this recent Robert Wood Johnson Foundation Commission is going to talk about this, but the foundation a few months ago released results from a national commission that was impaneled to make recommendations about how to improve equity-centered public health data infrastructure that goes into more detail about some of these general strategies mentioned here. So again, my email and contact information is available on the slides. Thanks so much. Look forward to the discussion.
Thank you very much. You finished under time. So kudos. So as our final, I don't have the agenda in front of me, but I think, yes. So we'll hear from Dr. Ponce from UCLA as our last speaker, and then we'll go into Q&A.
I'm sorry, I'm not able to share my screen. Maybe could somebody advance it for me? So apologies. It's a system failure on my end. not on
Sure,
your
one
end.
moment.
Thank you. Well, as Greg is teeing that up, I wanted to thank Dr. Mays for the re-invite for this session, and wanted to thank all the previous panelists because I've been copiously taking notes and taking screenshots of your slides for all the information that you've provided. Last time I specifically talked about the vaccine equity issues that were related to COVID-19 data equity issues, particularly for two racial ethnic groups, the Asian population and the Native Hawaiian and Pacific Islander population. Next slide, please. And the agenda and takeaways on the left panel are what I concluded in April of last year. And the main message that data disaggregation is related to data equity. And I think taking that logic even further, that there's no health equity without data equity. The specific examples were on two groups, the Filipinx AO population and the Native Hawaiian and Pacific Islander population. So the way forward, I actually didn't have very many recommendations in the way forward, because at that time I was grappling more with this place-based equity algorithms that had been put forth in with the intent of speedily targeting, the hotspots and areas of needs where we were seeing outsized tolls on populations. And so my main point was that some of these place-based equity algorithms might have blind spots, and then allocation of resources that are needed then are misplaced, communities are overlooked. So the way forward this time, just as a punchline, I'm mindful of time, is that to look at these place-based equity algorithms, what's happened, but also the data sources, the inputs that go into these algorithms, particularly since they do look at these social risk factors. And so many are sources for social determinants of health measures. And the big punchline here is community engagement. I think we've heard a lot about training on the local health department side and engagement with communities, but that's going to be my main focus. Next slide, please. This is your NCVHS health data framework goals, Dr. Mays, and so you want to help experts support the health ecosystem, surface the gaps, the high impact gaps in data sources and methods, and then catalyze the development of interactive tools. And I think among your panelists today, you've heard that there's a lot of progress, generally. I mean, there's some progress that continues, that has to continue, but I believe that there was discussion, I hope we have discussion today on how to continue this. Next slide. So on the topic of place-based equity algorithms, next slide. So there are many developers, and there's even newer indices, and it really is up to the developers on expanding this. I showed this last time, and there's a social vulnerability index put out by CDC, the area deprivation index, California Healthy Places Index, which is California specific, and at that time, the pre-existing health vulnerability index. And also at this point, it's California. So the main point here was that only one of these indices, the SVI, actually had an explicit input of minority status and language need. Next slide. So I'm updating a little bit. So there's still the SVI, which is widely used across different states and localities. And area deprivation index also still there. But I add from the Graham Center the social deprivation index, which actually had been around. It's not a new development, but just new here in my slides. And also from last time, as Dr. Mays had clarified that the pre-existing health vulnerability index was a component of a larger index called the medical vulnerability index that has been used, and which includes the social barriers that get at minority status and language, from the SVI, as well as citizenship status, with particularly in areas like California, which is 25% immigrant, is really important in getting at vulnerability. So next slide. So as I said, only 2 of these measures explicitly include race, ethnicity, and language. I'm going to shortcut it to REL, and non-citizenship status. And I'm not a developer of these indices, but we have in LA County, we have started to work with the Southern California Public Health Association that developed the HPI, the Healthy Places Index, in really thinking through how to best understand how these indices might leave out some populations. So starting to look at stratification by race, ethnicity, looking at the overlap of what community organizations are saying are underserved areas and what's missed by these indices and threshold levels. And so I think that at the local level, at least in Los Angeles area with local health departments and the index developer, that we are working pretty actively in making sure there's a version that will incorporate race, ethnicity, language, non-citizen status, as well as other variables such as multi-generational housing. Next slide. Thank you. So another development since April of 2021 was that the California Pan-Ethnic Health Network, which is a community-based organization, is a network of community organizations across the state that focus on health and social services, advocacy, that they put out a report, and I was part of this, on using the disability rights movement cry of nothing about us without us, and can area-based social indices effectively advance health equity. And so through a series of, talking to their community members across the state and looking at these various indices, they come up with some suggestions where there is a strong endorsement of directly factoring in race, ethnicity, and language and other domains relevant to measuring health disparities in these indices, but also a cautionary note that even if you do factor in REL, that you need to determine this impact on communities, particularly those who are smaller in size, like Native Hawaiians and Pacific Islanders, American Indians, Alaska Natives, and subgroups within the larger OMB categories that are heterogeneous, that are displaced or geographically dispersed. Absolutely don't use it as an end all. You need to pair these indices with other tools and strategies, including authentic targeted community engagement, and leading to structural reforms. I was so delighted when Dr. Bekemeier talked about this new domain of institutional discrimination, and that these is certainly something that is of import. I am frozen. I hope you can still hear me. Can you all hear me?
Yes, we can.
Okay, great. Thank you. And then matching the indices with of social determinants of health with the specific policy issues. A lot of these indices, the outcome variables that are being modeled are may not necessarily be valent to really what you're trying to solve. So for example, life expectancy is commonly used by the HPI, but or looking at different risks, and so making sure that in these predictive modelings that you're actually addressing specific policy issues. In one of the indices, they looked specifically at COVID-19 deaths, for example. So Then the relevant domains are available at the block level. I think David Van Riper was just talking about the accessibility of the Census 2020 data products, and absolutely that the denominator issue of using 2020 is important. Again, very important for smaller populations. With the Native Hawaiian Pacific Islander population, using the old denominators led to like implausible vaccination rates, of over 100%. So absolutely the denominator is very important. Next slide. So I'm just looking at time. So the data sources, next slide. We also did this this paper in the Journal of Health Policy, Politics and Law, looking at the federal data sets besides the ones from Department of Health and Human Services that disaggregated Native Hawaiian Pacific Islanders from the Asian category. And we found that, since 1997 with OMB Directive 15, that over 30% still fail to provide disaggregated NHPI data. And I think more and more you are seeing this in papers and seeing this in battle cries from advocates, that it is really feeling like this inaction and omission is a form of structural racism, or continues to produce structural racist barriers to that need to be addressed but aren't addressed because of the invisibility of populations in this data and these measures. Next slide. So I'm going to go through, so this is the review. We looked at, we expanded on a paper by Panapasa, Crab, and Kahulukula, and in 2011, and we looked at 29 national data sets in 6 agencies, in addition to HHS, Commerce, Education, Housing, Urban Development, Agriculture, and Justice. And next slide. So I'm going to just really peek through this list of how we collected the data and what the whether they were NHPI race was collected, where they're reporting and compliant with OMB. And also, since we use the previous work by Panapasa and all, that we looked at, is it improving and is it not improving since 2011? So that's the last column. But we're going to go through this very quickly, so make sure that we have time for discussion across all the panelists. So I have some questions for them too. Keep going, please, Greg. Just to show the different data sets. Please keep going. Keep going. And keep going. There's some notes of education, keep going. Agriculture, housing development, Department of Justice, like the census of jails. Okay, right. Oops. Okay, next one. Right. So I hope you can see this. This was just my attempt to try to summarize all of those results, but the right quadrant, right upper quadrant, are where there's compliance in collection and compliance in reporting across these data sets. The ones in yellow are the DHHS data sets. So some of these, we know off the top of our head, Sun Alphabet Soup, some Burfus, YRBS, NISDA. Some of them, I'll have to have a cheat sheet to look up if you're interested in it. But and then the census, ACS, CPS, the Survey of Income and Program Participation, the SIP. You see that there's collection and reporting. And then after Dr. Mays' presentation, I feel like there should be a third axis I have to work on in terms of actually access, like lowering this transaction costs for local health departments and for communities. And so we see that, there's a lot of there's collection and reporting seems to be fine. As Dr. Mays said, maybe the SNAP wiki couldn't access as well. But, again, this is what we found in the federal, state, and then there's more that where they're collecting data sets, but they're not reporting. And so this is summarized it here. And, really data sets that I use in NHIS and Haynes and MEPS are at that point where you do have to go through a secure data access center to get at granular race ethnicity data. And then these, 2 data sets here. Again, this is a non-exhaustive list of not compliant reporting. So next slide. So I think that there's, and we looked, as I said, is it improving? And there were definitely improvements where back in 2011 that 10 years, more than 10 years since the 1997 directive, that there was still a number of federal data sets that were not separating Native Hawaiians and Pacific Islanders from the Asian group or putting them in some residual category. But it looks like that there was improvements. So my conclusion is that the social indices, which is what I started with in talking about, since that's where I left off in April, that they are trying to address health equity, and they are absolutely important new tools in the federal, state, and regional policy making. But they have to address this underlying cause of structural racism, discrimination, and biases. Race, ethnicity is not a perfect proxy for that, but that would be a start. And so the limitations, though, on race, ethnicity, I really think, based on just my on-the-ground experience in Los Angeles in California, is that it does necessitate the inclusion of these community-centered strategies. And that is something that we really emphasize. As Dr. Mays has said, I was in the commission, the Robert Wood Johnson Foundation Commission, to transform public health data. And I think that just kept resonating in all the conversations that we had. The adoption of area-based social indices can supplement, again, it's a supplement, but should never replace authentic, intentional engagement with the communities that are being affected and impacted by these decision makings. And this has to happen during the planning, the implementation, the evaluation of any public health strategies. So I think the next steps are tools and the data intermediaries programs, such as OMH initiatives, and Dr. Bekemeier going to your, you may hear from me very, soon about how to make this happen. We did get a grant as well to do this in the Native Hawaiian Pacific Islander Data Policy Lab at UCLA. And the trainings are absolutely important. We've already completed a community assessment of 30 NHPI organizations. I won't talk about this now, it's very new. And particularly smaller communities. So these are our projects. I do want to end with the main takeaway from our community assessment is a lot of these organizations just don't know where to look and how to ask. So building dashboards and the training and how to do this and reaching out and having that trust is really important to improve data systems. So I hope you heard everything I said, because I've been frozen on the screen for a while.
We heard it.
Oh, okay, good. Thank
We
you.
heard everything, and it was
Okay.
fabulous. And I think I hear a lot of pop-ups in the brains, of a lot of questions. So Vickie, I may let you lead off on how we conduct the next section of discussion Q&A.
Great. We're going to start. I have a few comments, but given that many of them were covered by my colleagues, I'm going to make it very short because Dr. Ponce has to leave at 9. So I want to make sure she both gets her questions and gets to answer them. What I wanted to do is just bring to the attention of my colleagues that there is a report. Many of us know Cara James, who used to be the director of the Office of Minority Health at CMS. And their organization put out, she is the CEO right now of Grant Makers in Health. And they put out a Modernizing Race and Ethnicity Data in Our Federal Health Programs, which focuses specifically on issues that came up in terms of COVID. So, for example, I will send you there just so that you can see, for example, they went through, much like Dr. Ponce, and looked at places where the data is collected, whether they think it's complete or not, and what some of the issues are. There is a set of recommendations which were really covered very well by my colleagues. So instead, what I want to do is not go there, but just talk about this issue of, here's what we have to think about. We follow within the federal government in some data collection and report outs, the Office of Management and Budget. That was done in 1977. HHS also then upgraded their perspective on how to collect and report out the data in 2011. So part of the inconsistency that exists in the federal system is who uses what to report out where. And we haven't had an update since 2011. So you can see here, the differences in the two, and many things have to go through OMB. And here you can see the differences in terms of OMB in 1997 and HHS in 2011 in terms of ethnicity. So I just want to bring that to our attention, and what you'll be able to see is there's a whole set of recommendations which my colleagues have covered in lots of great ways that I will leave with the committee for us to work on later. But I'm going to stop there. I'm going to stop sharing there. And I'm going to open it up because there are members of the group that worked on this that actually have some questions. But what I'm going to do is try to take the, co-moderator's prerogative and let Dr. Ponce ask her questions first, because she has to leave, unfortunately. But can we get you to ask your questions, Ninez?
Yeah, thank you. My video is totally frozen, so I'm sorry. I'm going to turn it off. Because it's one question I had for Dr. Mays was there is the access piece, and in Dr. Mays, you'd mentioned something about access to social health information exchanges. Could you elaborate more on that? Because I frankly have never heard of those. And, should we have them, where are they available? So that's what I wanted to ask.
Fantastic. I think you're referring to the Glen Mays and
yes,
as
you.
opposed to Dr. Vickie Mays.
Sorry, Dr. Glen Mays. Yes.
It's
so
okay,
great to have it's so great to have another Dr. Mays on the panel. I rarely get that. Yeah, so social health information systems are an emerging piece of the data infrastructure we're seeing pop up in communities across the US. Basically, we can think about these many of them are being built on the platform of health information exchanges that were created, for hospitals and physicians to share electronic clinical information from electronic health records. Increasingly, those regional HIEs are building capacity to incorporate data from social service providers on social needs and social services received, particularly health-related social services. And so we're seeing a growing network of these social health information systems being developed. We're basically opening up regional health information systems to include data flows from housing providers, from food and nutrition providers, from people providing financial assistance, et cetera. And those social health information exchanges are being used to help identify people who have unmet social needs and help to navigate them to social service providers and close the loop. So they're really promising, but as I mentioned, lots of problems with again access to particularly public health access to those regional information systems, and then of course lots of problems with incomplete and missing information on race and ethnicity data within those systems. So if you're interested, there are a couple of national networks of these social health information systems. Two of them are sponsored by the Robert Johnson Foundation, and my group works closely with them. One's called the DASH Network of Data Across Sectors for Health, and the other related network is called the All In Network. And so glad to provide more information as needed.
Thank you. And I'm sorry, Dr. Mays, Dr. Vickie Mays, but I wanted to ask, I am on the commission, as I said, on the Robert Wood Johnson Commission, and they do have dollars, as Dr. Glen Mays had showed in one of his slides. So I do think that we felt that, the role of good data is still government role, right? And that it's where foundations and advocates come in is catalyzing either the coverage or the efficiency of the data systems, particularly in informing, the public health decision making. So I think something like the social information exchange would be one area, but I just wanted to get a sense from the other panelists on what they think would be ways that, an investment, a non-government investment in catalyzing and improving and modernizing public health data or federal data sets, like what would their recommendation be?
Anyone want to answer from the panel?
Yeah, I'll take a stab at that. I think it's a really great topic that we're on right now. In relation to COVID-19, I have, I've been working on this and thinking about it pretty nonstop for the past 2 years. And we did a paper looking at social class disparities in COVID-19 mortality, and we found very large disparities, which are also racial and ethnic disparities, right? Because we live in a system of racialized capitalism where the Black and Hispanic and Indigenous working class are more disadvantaged than the white working class, right? So we have both of these things operating. And I've really come to understand COVID-19 as a disease of the working class. The working class has been highly disproportionately impacted. And that is true across gender and across race. But of course, gender and race and ethnicity are independent risk factors as well, okay? So, and it also impacts children, because children, as you may be aware, are of lower socioeconomic status than adults overall. Children are more likely to be in working class families. And the fact that the majority of the cases and hospitalizations and deaths we're seeing among minority children is a very strong indirect indicator that these are kids who are coming from working class families. So for me, the main thing that I think is always missing is an explicit class perspective. And I think that the concern that I have, of course, I do a lot of work on racial and ethnic disparities, but I think there's always the risk for victim blaming, essentializing, and tying things to individual behavior or health education, knowledge, yada, 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 and not to the structure of work. And this is why I think it's very important to, when we use words like class and working class, then we can understand why certain groups of people have been at such higher risk than others. And it really does come back to the conditions of work and control over the conditions of work. So this is an area that I think we could see improvement across the board. And of course, it's a decades-long problem. And it's, what sets us so far back compared to many other nations, that we lack this ability to link in social class data to our health data systems. And so, with the area indicators, instead of always characterizing small areas by the percent of the people who live there who are Black or Hispanic, how about the percent of the people who live there who are blue collar workers or service workers, to try to just move away from that racial essentializing that we do so much of in America. Unfortunately, I'm not obviously talking about the people in this group, but it just, when we always put things in those terms and we never marry that with social class information, then it can be taken away from us and used and interpreted in wrong ways. So that's my piece on that. And I'm going to put in the chat, I'll put links. I'm going to put links to our preprints, which I hope you'll, take a look at. I think they're very useful. And Dr. Ponce, we do have disaggregated Indigenous Native Hawaiian data in there.
Great, thanks, Beth. I'm going to let Betty Bekemeier, Dr. Bekemeier also, she's got a hand up here.
Yeah, great. I want to just speak to the issue too of, I think Dr. Ponce mentioned the question of foundations, private funding catalyzing some of this work, but what's the role of the federal government? That's an example of that, is this work we've been doing with local health departments around administrative, standardizing some of these administrative data. Health departments have been kind of a black box in terms of what's being spent, what's happening in prevention services and delivery, and how resources are allocated and where they go and what they can do, et cetera, et cetera. Glen Mays and I and others have done a lot of work in this area in the past, but it's so limited by the data. The Robert Wood Johnson Foundation really did catalyze this work we did with the Uniform Chart of Accounts, for example. And so we developed it with practice partners. Glen Mays has been involved in this to a certain degree too. And so it's available, ready. We've got users using it, but it's so small. It's far too small at this stage. It really needs the federal government to invest in now really ramping this kind of thing up. And to me, it's there's only so much a foundation can do in terms of catalyzing these kinds of things, but they really are. I would totally agree that these are things that the federal government really needs to get behind and support, and then ramp up.
Thank you. These are great suggestions. Let me let the committee members in here. Does anyone of the committee members have a question for the panelists?
See no hands. Are there any hands out there that I'm missing?
Denise Chrysler and
Okay.
Val Watzlaw.
Thank you.
Sure. This question, I think it's mostly for Dr. Bekemeier, also maybe for Dr. Glen Mays also. And you both talked a lot about local public health workforce and the need for greater expertise in the building of local public health with regard to data collection and data analytics. To what extent does the development of the local public health workforce include attorneys? So I'm really, being an attorney, of course, I'm really interested in to what extent is law considered an important part to develop so that local public health has experienced public health attorneys who understand, for example, how HIPAA applies or does not apply to local public health, who can represent public health in negotiating over data with health systems, that sort of thing.
Yeah, I would say short answer, Denise, is not much and not enough. The very large agencies, they have lawyers. The state health departments have legal folks, et cetera. But we had, some years back, it's only been public health law programs at the national level, et cetera, have only been around for what, Glenn, 15 years or so. And it's been a growing area. And of course, in the last 2 years, it's been kind of really this whole area of science, et cetera, has been really devastated, and we really need more. So definitely this kind of public health law really needs to be bolstered and relooked at and supported in all areas of practice. And Glenn, I'm sure you have stuff to say about this too.
Yeah, I would totally agree. I think it's not enough emphasis. I would add that in terms of formal graduate training in public health, there is a recognition of the importance of public health law competencies, and they are included in graduate at the MPH level training in those competencies, but especially training public health professionals in how to work with their colleagues in the legal profession. And one other thing I might add is that public health as a profession has so far been left out of loan repayment programs like the National Health Service Corps that many clinical professionals are able to tap into. So that's another area where there could be a federal role is in to incentivize more graduate level training in public health that would include things like legal competencies, helping with loan repayment at that level.
Now,
Yes, thank you. And thanks so much for your presentations. I know I've been taking many notes, and so much of it I think is so concerning, and I appreciate the solutions that you also provided. My question is, I think, more for Elizabeth. I think you had ended your presentation talking about vaccination data as well for children, but I wasn't sure. Are you seeing the same gaps there as you saw with the other data? And if you could talk a little more about that.
Sure, I'd be happy to. So the CDC releases a data set every single day. It's updated daily, and it's pulling in data from the states on vaccinations. Now, these are counts of people who fall into different categories of vaccination, okay? And they do have data on children, which is great. The age categories are not very fine. We have 65 and older. They put out 18 and older, 12 and older. So we subtract to get 18 to 64 and 12 to 17. And now we have 5 to 11 data. There is no race and ethnicity data at all released in the vaccination data. Okay, so any race and ethnicity vaccine data that you're seeing coming out of CDC is from smaller samples. It's not national surveillance data. Now, having said that, like I said, as part of COVID, I visit the state health department dashboards all the time. There are a few states that do report vaccination data by race and ethnicity. We haven't been tracking that directly. Which is not because it's not important. It's just really a function of, time and funding and all of that. So, I suspect that, we're going to see the same kinds of challenges that we've seen with access, although I have seen some encouraging reports of local health department efforts to really ensure that equity is maintained in distribution of vaccines. I think that the local public health community has really risen to the challenge of that. At the same time, I think that White House and certain federal decisions to put vaccines in the hands of commercial pharmacies rather than focusing on the government, local public health, has created some equity issues. And let me expand on that a little bit. What happens in the commercial pharmacies, even though the vaccines are free to everyone, if you go into CVS or Walgreens, you will be asked for your insurance information, okay? Now, for people like us with college degrees, and getting back to my theme of the working class, for people with education, this is maybe not intimidating. We just say, no, here's my insurance card, fine, charge them if you want to. I have insurance, no problem. But for people who don't have insurance and who are being faced with, oh, fill out these 2 pages of forms, show us your insurance card, where's your ID? I have heard numerous stories of people just turning around and walking out. That all of that information gathering, trying to charge insurance is a barrier to vaccine uptakes for working class, minority, and immigrant populations. So so I think it's highly variable what's going on at the local level. I think we still have a lot of work to do in terms of equity. And the other thing, if you look at our dashboard, we are analyzing the data and this applies for all ages, not just kids. We are analyzing this daily CDC data to account for waning effectiveness. And one of the frustrating things that's going on is the CDC's reporting on vaccination is basically cheerleading, okay? And the reality is that we are not in good shape. The majority of the population is not optimally immunized, meaning that many people have not received their booster dose. This is especially true for teenagers. So you can go and you'll see the maps. There's state data, they're by age, and we wane the data. So if after 5 months, people have not received a booster, then they're no longer in our top category, which is optimally immunized. And so we still have a tremendous way to go in terms of vaccinating the population. And you would not know that from the way that the statistics, we get a lot of numerator only reporting. Oh, 1 million doses. Well, okay, but what's the denominator? Like what percent of people have actually gotten what they need? And this happens from CDC, and also state health departments are doing that kind of cheerleading. And it's not always giving the most accurate picture, which is not a very positive picture of where we are right now with COVID vaccines.
Thank you. Woo.
Okay. First, thanks all the panelists and the moderator for this great panel. I have a question for Dr. Bekemeier. In your last slides, you have the recommendations, but the last one, you just have mandates. Because run out of time, you didn't talk about that. Yeah. Could you explain a little bit more detail what mandates you think we should have?
Yeah, good question. That's more specific to the what I was thinking about there is our finding in relationship to public health administrative data. We have developed these standard data systems, particularly around financial data that seem to work, et cetera, but it takes some initial investment and some initial effort by health departments. And our experience has been that frankly, what's really going to make this ubiquitous is if it's mandated. Kind of like other similar data are mandated in for healthcare systems, et cetera. And it's kind of a dirty little secret with health departments themselves. They don't like more mandates, frankly. So it's nothing that we necessarily broadcast or talk about frequently with our public health practice partners themselves. But clearly it would get folks over the hump in terms of actually implementing these systems. And it's going to take incentives. It's going to take some upfront investment, federal investment. It doesn't take a lot. We know, we figured out how much it would cost, and frankly, it's a one-time investment upfront, and then just some ongoing maintenance, et cetera. But the effort it takes is not huge. Even that is not huge. But folks need, pretty encouragement and a more wide. We've already pulled in the early adopters, right? And the more data you have, the more valuable they are. And to bring in other folks that sort of need stronger encouragement. That's our sense of what it's going to take.
Thank you.
Great. Thank you. Dr. Spielman has to go, so I just wanted to see if there were questions for him before he has to jump off. So are there any questions that are specific to their presentation? Okay. Tammy, I can't tell, your hand is up. Is your question for him, or is your question, or Denise?
No, I think Tammy's and my hands were up before.
Yeah, but is it, but anything specific? Okay. All right. Dr. Spielman, I will let you go. David, I'm hoping you'll stay a little longer. Thank you. Okay. Oh, Tammy's hand is down. Okay, Denise.
Yes, this panel is fabulous, and I feel hope that in a hard time that folks like you are working on these intractable problems. The theme we've heard, and this is for Dr. Mays, Glen Mays, we heard yesterday for public health emergencies, one of the solutions that might be a lower hanging fruit is better use of existing data, even with all its problems and flaws. And you mentioned limited access to these Medicaid, APCD, and hospital discharge data sets. They are out there, and my thinking is that should be one of the low hanging fruits that we could solve in a short amount of time. And I worked in these databases for long enough to know that sometimes the locals don't know the people who are running the data systems, or the MOUs are too long and too lengthy to develop. But it seems that there is a solution there that we should be able to find. Am I just drinking Kool-Aid or something?
I think you're right on target. These are the existing data systems. We do have, defined mechanisms for granting access through data use agreements, and I think there's issues of lack of knowledge at the local level, how to navigate those mechanisms, and as was mentioned earlier, lack of access to legal expertise that can be very effective. We don't have nearly as many, JD, MPH educated people with legal and public health expertise embedded within these state and local systems to navigate them. But I would definitely agree that is a potentially relatively low-hanging fruit way of expanding local access to these data. But we would need significant capacity building, I think, to help broker those data relationships.
Right. The data are there, and I think some of that access could be evened out. But I do think, as we're talking federal support and brain power from Dr. Ponce and others, we could do maybe a better job of building in indicators that these data could populate that would also feed some demand and smooth out some of these access issues. So that's, I'm glad that you agree, because that when you mentioned that, I highlighted that in my notes. I will turn it over now to Tammy in the interest of time.
And I'll be short, but I did want to commend Elizabeth. I really appreciate your co-KID project data quality report card, and that you're identifying the minimum data set and making awareness of the gaps that are out there. But recognize that these data sets are only as good as the data that the state health departments get. And with COVID, I come from the healthcare setting perspective, and so that's where my comments are coming more than from a researcher. And I'll tell you that the COVID-19 data request from the state and local government was very burdensome, and just as burdensome as the Dr. Glen Mays, you were talking about all the needs and the improvements, is the same on that setting side. And so I'm just wondering, Elizabeth and the other presenters, what do you think of, how do we identify, kind of like the Gravity Project, where they're looking at the social determinants of health, they're working through the ONC efforts to get those data in the EMRs. And then the other point is, how do we put it in the workflow so the collection of some of these data points that are needed becomes more of a routine instead of a burden, with an electronic means of exchanging that information. So, these dashboards can be automatically fed, because right now it's extremely manual, and every local department, every state department has different data elements, have different definition of those data elements, requiring manual entry. And someone mentioned portals, and I just kind of flipped out, because, this portals are not an answer. I mean, COVID-19 was manual update of information that had to be collected from systems that were not in the EMR or PMS. And so I know we can go on and on about where incentives and others lie, but my question, to Elizabeth is where do you see the primary data source for these gaps, and how do we begin to move toward that accurate collection? I'll be quiet because I could go on forever on these questions, but just looking more for solutioning and more conjoining of the medical healthcare community with the public health and the research needs that we know are extreme priority.
Right. I mean, I totally hear you. And I think, I would say that even the situation has even gotten worse recently, because I think with the Omicron surge, that many state health departments are literally just cracking. I can tell you that I have seen more dashboards being down, just not being updated at all. The state of Maryland was subjected to a ransomware attack. Their dashboard was down for 2 solid weeks. I'm still amazed by that. I'm still so curious to find out what's the behind the scenes story of why it took them 2 weeks to put their dashboard back online. And we have late updates there. There are states where they say, we've updated, but it's not accurate because we have a backlog of 20,000 cases that we have not been able to process yet because the volume has just increased so much with Omicron. So it's an intractable problem. In the solutions are staff and money. With COVID, the problem starts right at the labs with the testing. When we don't collect race and ethnicity and basic socio-demographic data on the people who are being tested, then that's where it all starts. That's where the data system starts, is with those tests. So I think Betty really hit the nail on the head, that the way that you make these things happen is you mandate them. The reason why we have daily reports on COVID hospitalizations from every single hospital in the United States, which is over 5,000 hospitals. The reason why we get that is because CMS tells them, you have to give us this information or we're not going to give you your Medicare money. So CMS has a really big stick that they can use on the hospitals, and the hospitals don't like it and it costs them money, but they have to comply, and they do comply. Now, I'm not saying that that's the ideal model, but there are countries where there's a national data set. It's basically the census, okay? You've got names, you've got family information, you've got educational attainment, you've got occupation, and that data can be linked to every other data system. Hospital discharge data, link it to that census data, vital records, link it. So, and we lack that in this country for some reason that I really fail to understand. I mean, it's political, obviously, but so it's so easy to do things in other countries that it's extremely difficult to do here. And then we make people provide the same information over and over and over again. Every time they go to a different place or they're in a different location, they got to provide the same information because there's no behind the scenes linking or connecting of the information that people are providing. I wish I had like a great solution, but I think everybody is well aware of what our structural limitations are in that regard, and it's going to take a lot of concerted effort to break down some of those barriers.
We've got about 5 minutes.
No.
We've got about 5 minutes left. So let me just check in with others on the committee to see if there are any questions. If you were not in the small working group, if any of you want to ask questions, please raise your hand. If not, I'm going to close this out using letting these last couple of comments. I don't see any other hands, Denise, unless I'm just missing it.
Dr. Bekemeier, did you get your comment?
Well, I was just gonna sort of reinforce this idea, like with our Share Northwest project, it could be considered a pilot. It was just 4 states. But it really speaks to this issue of the degree to which we have existing data is great, and it has some utility, but if it's not accessible, and I put it accessible in quotes because it means, spreadsheets, and having a bunch of spreadsheets available to people, or even a flashy dashboard that doesn't meet their needs, is not accessibility. So really linking existing data sets that people need, putting it together in a useful way that meets their needs on the ground is really and developing that capacity for utilizing the data is so necessary. And that's something we've really found with this project. And there's so much more that could be done in terms of scaling it up and implementation science. What gets people to use these data better? How do they make different and better decisions? How do they allocate resources in more equitable ways, et cetera, et cetera? There's so much more that can be done with that. And again, it's sort of this low-hanging fruit around data that already exists, and the data will be better if people are using it as well.
Great. Let me just ask a question because I would be remiss for the researcher in me if I didn't. And it's for David Van Riper. Have you all developed any tools that can make it easier for individuals who work on data to be able to deal with the denominator issue? You have either technical reports, data tools, because my concern is that, as you can see, the best, approach to some of this is to bring it down. So in terms of having public health workers, in terms of Dr. Ponce talking about her community people, but this is very complicated, in terms of doing this work and getting it right. Any things to give us?
So as of now, most of our data products here at IPMS and Minnesota Population Center are more focused on researchers, right? That's the typical user community we've worked with. We're starting to have conversations with public health scholars here at the U of M about how to create that next layer of data that's more accessible for local health departments and local health professionals, trying to figure out what can we do to make it easier to access our data. Now, unfortunately, that's hard for us. We have so much data that it's really tricky for us to know how do we engage with the local community groups to know what are the useful data points that they need, and separating the core of what's important from like the massive volume that we have. And so my work with some of our faculty here at the U of M have helped me get a better sense for what those kind of high priority data items are. And I think, we're working on a product that will hopefully be a census tracked data set from 1990, 2000, 2010, and today that lets you measure change over time for local communities for income, race, age, employment, educational attainment, that standardizes all of that data. So something's coming, but we haven't quite figured out how to build the systems that meet that varying level of expertise.
We'll put you together with Dr. Ponce, but I just want to thank the panelists. You have done a great service for us in terms of giving us insight for what our next step should be. If it was left up to us, we would just keep you all day, but we better do other government business here. So I want to thank each of you for your contributions. I could see my colleagues and their notepads and what have you. So I will say I'm pretty clear that we're walking away with some very important information to help us to determine what it is that we should say to the secretary to be able to help us. So I appreciate the time that you gave to do this. I also appreciate that many of you were very honest about what the problems were. And so we will take it to heart that we have the responsibility to be reflective of what we heard from you. So I think I will say, everybody give you a hand, and I will turn this back over to our chair, Jackie Munson.